Okay, we're going to go ahead and get started. I'm recording this so you can watch it later. We're going to talk about stroke and seizure, and this will be 15 to 20 minutes. Hopefully it'll be pertinent to your work on the ski hill. And let me start sharing my screen. And this should get us going. Here we go. Hopefully you can see this. I'm going to talk about stroke and seizures. And just a minute, let me get this thing working a little better. Okay, you can all see what you missed last night from fire jumping. Right there. Anyway, I'm going to talk about stroke and seizures, a little bit on anatomy and physiology, just it'll help your understanding, and then mostly on stroke and a little bit on seizure. The anatomy and physiology is the same for both, and mostly on stroke and a little bit on seizures. So let's start by a call you get, 72-year-old male who falls getting off a chairlift. You come to the chair, top of the chair, and just find him sitting on his side, and you're appraise the scene, and you don't really see any injuries. There's no blood. Your primary assessment, everything looks normal. He's sitting on the snow and he just can't get up. His chief complaint is he lost his balance. In your secondary assessment, you do a quick sample history. He has a history of heart disease and diabetes, and you do a real brief exam on the hill because he states that his only symptom is that he lost his balance. He's in no pain anywhere. You take a look at him and he has a left-sided facial droop like this. He's weak on his right arm, and I'll explain what the quickest way to assess that is. And so now you're thinking, this guy really didn't get injured. I think he's having a stroke. So the key here is, what do you do? And it's rapid transport and EMS call on this patient. And once you identify that the patient is having a stroke, and I'm going to show you the most important slide, 2 slides here right at the beginning and then again at the end. And this is what we use in the ER to assess stroke. You've probably all learned the FAST, which is face, arm, speech, time. And we just, we use BFAST. So it's balance, sudden loss of balance is what this gentleman had. Eyes, they either have double vision or a quick assessment of their field of view. They may have a loss of vision when you wiggle your fingers in front of their periphery. They can't see until they get in front of them. Face, they have facial droop, may have a facial droop. Arms, sudden onset of arm or leg weakness. The arms, the A is for arms and legs. Best thing to do for that is you just hold it up, and if they can't understand very well, if they're a little confused, hold their arm up and ask them to hold it up as opposed to lifting your arm up. If you hold their arm up, everybody will do that, and ask them to keep their arm up. Same with their leg. Put their leg up and ask them to keep it up if they're confused at all and don't understand. The S is for slurred speech, slurred or garbled speech, and time. This is very important. Last seen normal. If they can get to the hospital within 3 hours, I'll explain this in a little bit, they can get systemic TPA, which is a clot buster medication in their arm. Under 6 hours, that same medication can be given up through an artery and directed into the actual site of the blood clot. But it's best, the earlier you get to them, the better. Okay, so that is, like I said, the most important thing to learn from the whole thing. If you want to go skiing now, just go ahead and go. So it's BFAST, balance, eyes, face, arms, speech, and time. So now I'm going to talk a little bit on anatomy and physiology. Just then you'll get kind of more credit for this than just me telling you if they're having a stroke, get them off the hill in a hurry, which is still the most important part. So the anatomy and physiology, the brain is the body's computer. I'm not sure if it's a Mac or a PC. Three major parts of the brain are the brain stem in the back, the cerebellum, which is in the back, and the cerebrum, which is most of your brain. Here we go, the cerebrum up front, the brain stem is this yellow here, and the cerebellum, which is mostly involved in balance and coordination, is this little thing that sits in the back of your brain. The brain stem controls functions such as your pulse, your swallowing, pupils. It's where the cranial nerves come from that operate the pupils, swallowing, breathing, etc. The cerebellum is coordination, and the cerebrum is everything else, which is mostly speech and motor function are the big things in the whole front, the cerebrum. So again, cerebrum, cerebellum's back here, the brainstem's the yellow part here. The cerebrum, that's where you think, your memory is, the motor function, your speech, as I mentioned, and vision is the back part of your cerebrum. The occipital lobe is this vision right there. Cerebellum, as I mentioned, is coordination. People that have a stroke in their cerebellum may only complain of dizziness. They feel like the room is spinning, or they're just falling to the side all the time. And that may be their only symptom of a cerebellar stroke. And we see those fairly frequently. The brainstem, it's less likely to have only a brainstem stroke. When you have a stroke in your brainstem, it's a bad deal because it's involved in your vital functions. And I guess that's what happened to SpongeBob here, brainstem stroke. The circulation, now here, this is important for stroke physiology and pathophysiology. You have two blood supplies to your brain. One comes up from the front through your carotid artery, and the other one comes up through the vertebral artery. And see, it's in there in the arches of your cervical vertebrae. And so this thing is really protected well until you break your neck, and then it's not, the vertebral artery. And that we see injuries to that, and people can have an acute stroke from a car accident. We see that fairly frequently as well. But these communicate, I'll show you a better picture in a second, through the circle of Willis, the posterior circulation and the anterior circulation, which is a good thing because that helps people recover from a stroke if the one system is still intact. Again, here's circulation. The vertebral arteries come up, they form one basilar artery, and then they connect together in the circle of Willis here. These are the two anterior forms, the carotid arteries from the front, and the two vertebral arteries down here form one basilar artery. They come together and call this circle of Willis right here. And so you can get a clot in one little area, and hopefully you'll get some communication and blood supply from the posterior part, or vice versa. With regards to strokes, most 88% are ischemic. That means you either have a blood clot form at the site where you have a thrombus, or you have a blood clot that is thrown from somewhere else. And that's the most common place is the heart. In people that have atrial fibrillation, their heart doesn't contract properly, and they can form a clot in the heart, and then the clot breaks loose, goes up through the carotid artery, or it could be the vertebral artery in the back. And that is called an embolus, as opposed to a thrombus. An embolus gets thrown from somewhere. A thrombus just starts and from atherosclerosis and gets bigger and bigger, and then gets to a critical mass and forms a clot. Most are thrombotic. 61% of the ischemic strokes are from a clot that just gets worse in place. Hemorrhagic strokes They account for roughly 20% of strokes. And they typically present with bad headache and um, quickly deteriorating mental status or neurologic symptoms. And these happen very quickly usually, and are usually associated with a bad headache. And if it's a young person, it's usually due to an aneurysm that they were born with, which is a little defect in a blood vessel wall. It looks like a little balloon popping off the blood vessel wall. That's an aneurysm, and that can occur in young people. That breaks and it causes a horrible headache. Most ischemic strokes, which are most strokes, do not have any pain or headache with them. I'll talk in just one sec about hemorrhagic strokes. Speech is controlled on the left side of the brain. In most people, it's interesting. Many left-handed people, like half of all left-handed people, have bilateral speech centers. So a left-handed person can have a stroke and not affect their speech. Whereas if it occurs on the left hemisphere, they'll have right-sided weakness. A right-handed person, if they have a stroke in their left hemisphere and they have the associated right arm or right leg weakness, usually their speech is affected. It's interesting that left-handed people frequently have bilateral speech centers, so they can get a stroke in the left side and not affect their speech. So stroke, it's also called a CVA. It's basically interruption to the blood supply to the brain, results in loss of brain function, lack of oxygen, causes the brain cells to stop functioning, and they begin to die within minutes. We'd like to get to them within 3 hours to open the blood vessel back up, as I mentioned. So they will regain some of this back, and a lot of people with a stroke will regain the function, partially due to the fact that maybe the insult didn't last that long, and then those brain cells will regain their function because they weren't completely dead, and they get blood supply coming from the opposite part, either the posterior or the anterior. Ischemic stroke, as I mentioned, we'll go through this quickly because I want you to not be bored with these things. Most are from atherosclerotic plaque. Hemorrhagic stroke, 13 to 20%, bleeding inside the brain, as I mentioned. These can be really bad, and especially if they're on blood thinners. Older person on blood thinner just has a sudden onset of a bleed. That's a hemorrhagic stroke. And if you do have an aneurysm and you have high blood pressure that's not treated, that's a really bad prognosticator for developing a hemorrhagic stroke. There's a berry aneurysm right there. That's like a berry on the outside of the blood vessel. That's at risk for causing a stroke. Hemorrhagic stroke, sudden onset of headache, and then they a lot of times in a hemorrhagic stroke have a high blood pressure and low pulse. So remember that. TIA is basically stroke that clears up in less than 24 hours. On the ski hill, hopefully you'll get them off the hill before you even recognize that it may clear up. You may get them off the ski hill, they come down to us and they're totally normal. That would be a TIA. Signs and symptoms, it can be anything from facial droop to numbness to one arm weak, speech problems, vision problem if it's in the occipital region, balance, as I mentioned, if it's in the cerebellar. But what we do is we have the paper for the Be Fast. That's the most basic things for physical findings of stroke. Aphasia, that's just the difficulty of expressing words. And you can get into the types of dysphagia or aphasia, dysarthria. That's just you can't pronounce the words. You know what you want to say, but your mouth doesn't want to make the words out. Sudden onset of severe headache, that's in a hemorrhagic stroke, or confusion can be in either stroke. Again, more signs and symptoms of stroke. As I mentioned, left hemisphere, if it's in the left hemisphere, the way the nerves come down and then cross, anything in the left hemisphere below the neck is going to cause right-sided symptoms. Okay, so if they have a stroke in their left cerebrum, it may cause left-sided facial droop, but right-sided hand weakness or leg weakness. And in most people, if it's a left-sided stroke, depending on where exactly it is, they'll have some speech problems. Just the opposite in the right hemisphere. Bleeding in the brain, again, it may be the bleeding may be caused by untreated hypertension, but also even if they don't have hypertension and they get a stroke, a hemorrhagic stroke, that person's blood pressure, because of the increased intracranial pressure, the body tries to compensate by increasing the peripheral blood pressure to get more blood into the brain. Increasing blood pressure, as I mentioned, is an important sign. Okay, conditions that may mimic a stroke. The most important one here is hypoglycemia. That is if they're a diabetic and their blood sugar is low. So if you have the ability to check a blood sugar, or the patient has the ability with them, if they're a diabetic, I have seen absolute complete picture of stroke, meaning aphasia, loss of function of the right arm, right leg, and their blood sugar is 40. As we're getting everything ready to work them up for a stroke, we give them some blood sugar, some glucose IV, and their symptoms completely go away. It's unbelievable when you see this. Or it could be a seizure. That's the second most common thing to worry about in a condition that may look like a stroke. Seizures. I'll go over this briefly. It's a neurologic episode caused by a surge of electrical activity in the brain. Most people know what a generalized tonic-clonic seizure is. That's the shaking arms, leg, clenching their lips, biting their tongue, loss of consciousness. And then there's the second one are simple seizures, where they're not, they don't have a loss of consciousness. One arm may be shaking. And then there's the petite mal ones, where they used to be called absence seizures. They may just be fluttering their eyes and kind of looking off into space and fluttering her eyes. That's the most common type of absence seizure. Partial seizure, as I mentioned, it may just be weakness or numbness, or some twitching of one hand or finger, but they're usually awake during this. The most common one still that you need to worry about are generalized tonic-clonic seizures. And these are frequently in people that have a known seizure disorder and they have an aura. Aura is something they experience. It may be a bad smell or the vision change, and they know the seizure is going to happen. And that's called an aura if that occurs before the start of the seizure. Looking at the clock here. I even brought candy to see who gets the answers to the questions, the virtual candy. Okay, again, muscle activity, rigidity. The key here is if most of them will last 3 to 5 minutes, and then they're in a post-ictal state for like up to 20 minutes afterwards. They're tired, not coherent completely. They may have kind of gurgling respiratory respirations and elevated respiratory rate, and tired. And that's the post-ictal state. If it goes on for greater than 5 minutes, we'll go through this quick. If it goes on for greater than 5 minutes, then that's status epilepticus. Or if it goes on for a few minutes, stops, few minutes, stops, few minutes, stops, and then, but those episodes go for 30 minutes, that's also status epilepticus. And these people need rapid ALS intervention for an IV or rectal Valium to stop the seizure. Many people will have a known seizure disorder. And so they may not, once they wake up, their family is like, yep, this happens once a week, but they just wanted to go skiing. You know, he doesn't need or she doesn't necessarily need to be transported to the hospital. If it stops, they clear up, they have a known seizure disorder. But if it's a new seizure, then these are some other things that could cause a seizure. And again, hypoglycemia can cause a stroke or a seizure. Overdoses, the most common overdose thing is an alcoholic who quits drinking and decides that the way he's going to quit drinking is to go to the ski area and be in the sunshine, and he may have a seizure, or she, because now they're not drinking, and those are withdrawal seizures. And they look exactly the same as just a generalized tonic-clonic seizure in a patient with epilepsy. You wouldn't know the difference. Same with a hypoglycemic seizure or a drug overdose seizure. These you can't tell by looking at them by the seizure itself. You get it from the history, or of course we do tox screen, et cetera, if they're in the hospital. The postictal state I already mentioned, scene size. So what happens in any of these? So now we're getting in, I'm going to do just the last 3 minutes on assessment. Scene size up. As I mentioned at the start with our person that fell off the chairlift, what happened here? Ask people. Look for life-threatening conditions, perform a rapid exam, gather information from the scene, from bystanders, and whether it's a stroke patient or a seizure patient, you need to use an ABPU or a Glasgow Coma score in your report. I got a patient, a 72-year-old male who looks like he has had a possible stroke. He's awake and alert, etc. The biggest thing again, and the primary assessment with any neurologic problem is their airway. A stroke patient may need suctioning, or a seizure patient may need suctioning. So those are with the primary, the ABCs of a stroke or a seizure. And then a rapid transport decision. So we want to get the stroke patients down to the hospital so that we can help them. The brain is, time is brain. That's why the T is on the B fast. The last thing is the T. You want to document what time they were last normal. Okay, history taking, a sample history. The most important things there are past medical problems and medicines. If they're diabetic, are they on insulin? Secondary assessment. Obviously the neuro exam is going to be the most important part. And the on-hill neuro exam, can you hold your hands up? Can you smile? Like so, and they may say they're smiling and that one side's not going out at all. And they think they're doing a normal smile. Can they hold their arms up? If they're lying down, can they hold their leg up? In terms of a rapid neuro exam on the hill. Vital signs when you get to your secondary assessment, if you get to that point and you're down at the patrol shack, and if they have a really high blood pressure and slow pulse and a bad headache, think about an intracranial bleed as a cause of their stroke. This just goes over the different stroke scales. The EMTs are taught the Cincinnati stroke scale, which is basically face, arms, and speech, part of the B-FAST. So the B-FAST, this again is the single most important thing, is their balance, facial droop, arm drift, and how their speech is. You can just ask them some questions and see how their speech is. And then the time. So the time is very important. The patient that we had that at the top of the lift who's having a stroke because he can't get up, again, you document when he was last normal. And he might say, well, I was completely normal and I got on the chair. And so then you know, like, well, he got off the porky chair and the porky chair takes 12 minutes. And his last time that he was normal was 12 minutes prior to that. So because that becomes very important in the hospital, we want to know, because we don't give systemic TPA if we know that it's been longer than 3 minutes or 3 hours, I'm sorry, 3 hours. So you may be the only person that knows that. You need to communicate that information, last time normal, to the EMS, then the EMS communicate it to the ER, et cetera. Because the family may be gone, they may go to the other hospital instead, they get mixed up, lost in traffic. And so it's very important because we dictate which medicine, and these are very powerful medicines with lots of side effects, and we don't use them if they're outside the time window. So you have to help us document the time that they were last normal. These are just the stroke scales. We don't need to do that. Reassessment, you're going to reassess everybody. And another thing to mention here on your exam or your treatment basically look for oxygen problems, check their SAT, suction their mouth, and don't give aspirin. Why don't give aspirin? Because it could be an ischemic stroke and aspirin will make it worse. So chest pain alone, give them aspirin. Stroke, seizure, don't give them aspirin. It could be an ischemic stroke, blood in their brain, you're going to make it worse. I'll go through these really quick because I'm over the time. This again is what I feel is the important thing. Be fast. Balance, eyes, face, arm, speech, time. So any questions there? The old patrol shack at Snow Basin. I can recognize Hershey, Holly, Fife. I know this guy and I just can't picture his name. Are there any questions at all on this? Let me look at the chat thing. On the Zoom. I don't see anything there. So we will stop the recording and then it'll be available to you to watch later. Hopefully that was beneficial.